Well, welcome everybody. Nice to see such a large turnout. I'm going to begin the presentation today by sharing some things. First of all, this is my absolutely favorite topic to talk about. I consider it a super talent to be able to use this skill. It is single-handedly the most important thing I have ever learned in my medical training, and I didn't learn it soon enough. I would probably say that at least my medical education put me more in a position of feeling full of knowledge and trying to understand why people wouldn't just do what I suggested they do. And I wish I had learned this sooner. And practice this far earlier. It has also personally been the solution to help me with individual wellness. I think one of the most frustrating things sometimes in healthcare is not seeing people get better. And this skill and this technique is really not about owning that in your sense, but helping foster a member's journey or patient's journey to help them own their success. And it really is a phenomenal, important frame shift, I guess, in healthcare for me personally to have learned this skill. I also think it's not easy. If you haven't practiced this before or seen this done, it can feel kind of strange. And so this is really just an introduction about motivational interviewing, but this is something that to really become good at and feel natural at really does require some practice. And I spent some time doing a lot of extra learning about how to do this and practicing it. And it's really helped me get to a place where it's very natural for me to do this. And it's hard to turn off once you get started, but it was not at all easy. And so today I'm going to really outline some of the theories and skills that go with this and sort of that frame shift approach. I've done a lot of videos at practicing this and done some more advanced teaching on helping people develop this skill. And if that's something that you're all interested in, we could actually make that a topic for future echoes where we kind of do like live presentations and skill development. But today is really more of some of the didactical theory and frame shift foundations of this skill. But as I said, it is my absolute favorite thing to talk about. So with that being said, I'm going to share my screen. Can you all see that?
Yes, we can. Thank you.
So we're going to talk about how to evaluate behaviors and identifying behaviors in healthcare where your brain might want to think, oh, maybe I should think about motivational interviewing for this goal. We're going to talk about models of change. We're going to talk about terms in motivational interviewing of ambivalence and discrepancy, and how to use those as identifying points to really have success and move forward. You're going to hear the term spirit, the spirit of motivational interviewing. It's really a core principle to how you as a provider approach it. And then we're going to really talk about the actual skills and techniques that go along with this. So the first thing is really, in behavioral healthcare, I mean, it's in our title, we talk about behavior problems or behaviors that are problematic. And I think that can be very pejorative to a lot of people. People can view behaviors as just something someone can fix. And so I think it's really important when you hear any behavior, you really think about it beyond the B or the behavior itself. Of course, the behavior is what is it? And you can do this with any behavior, even behaviors you're like, I don't even know what to do with that. I've given this example before. What if the behavior you're targeting is a child eating their own feces? And you're like, what do I do? Well, you start by finding out, well, how often is that happening? When is that happening? You get all the details about behaviors, but you can never change a behavior, ever, 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 if you don't understand what's happening before the behavior or what's happening after the behavior. And so whenever we talk about understanding behaviors, the A's and the C's, the antecedents and the consequences, are really what is going to determine any chance of change or success. And so antecedents are understanding what is leading up to the behavior. Why is the behavior happening? Is this coming from something that's emotional? Is this coming from situational stressor or cue or trigger, a biological one? And consequences are understanding what happens after the behavior. Some behaviors maintain themselves because it's an enjoyable, pleasurable behavior, where the immediate consequences don't outweigh the long-term consequences immediately in someone's brain. Sometimes the consequence is reinforcing. I use a simple example, but what if your child had a tantrum every time you checked out at the grocery store because they wanted a candy bar? And you were frustrated by the tantrum, and the tantrum never ceased unless you gave your kid the candy bar. So you're going to the grocery store every week, kids getting a candy bar, and you're trying to prevent this tantrum. Well, you just really taught your child how to get a candy bar. And so you really have to go back and figure out how to unteach that behavior that led to getting the candy bar. And so it's really important that you think about the before and after. And those are very unique and individualized answers. And that requires a little bit of digging. And you got to get people to open up. And motivational interviewing is a way to kind of elicit that information. So when we think about healthcare, there's lots of behaviors that interfere with health. And although this is a psychiatry discussion, not all of these are direct mental health concerns. Certainly smoking, substance use, and some of the other behaviors are frequently used that. But what about getting people to take their insulin? What about remembering to pick up your prescription? Those are all things, attending appointments, those can all be really important behaviors that interfere with health, and things like exercise, healthy eating, all of this applies. And so these are all behaviors that we can think about using motivational interviewing for. So ambivalence means that the person is uncertain. And ambivalence can be really frustrating, I think, to a lot of providers, because, there's a reason people's behaviors continue. As I said, usually if you're doing something that is unhealthy, you like something about that. Let's say you really like chocolate, and you shouldn't eat chocolate because it makes your blood sugar go off the wall, but you really love the chocolate. So you're really conflicted. It's not easy to give up something that's positive to you. And so ambivalence is really that idea of uncertainty, or not really being able to tell the benefit of the pros versus the cons of the behavior, or being really stuck with indecision. And it can feel paralyzing sometimes. What I would like to point out, that having ambivalence, meaning that there are pros and cons, is actually the perfect sort of trigger to think about using motivational interviewing, because that is really what it's targeted at finding. But in order to do that, you have to think about it as something to explore. So when people aren't doing what you want or aren't making choices, again, that little bell goes off in your head. I want to understand this. And so it's important you start asking people, well, what do you like about this behavior? What do you not like about this behavior? What do you wish you could change? Really getting people to think about the construct and just putting it out there as something they can think about changing. And then as you start those discussions, you really start listening for, amongst the ambivalence, where there's discrepancy. And discrepancy is really understanding someone's long-term individual goals versus what behaviors might be. So I might like my chocolate and it gives me an immediate sense of wonderfulness. I can give myself more insulin. I don't need to, I got it under control, but maybe it's not consistent with my long-term goal to lose weight, or to not get that awful feeling I have when my blood sugar spikes. And so, you're listening for this discrepancy that exists, and discrepancy and ambivalence can go back and forth. But that's the perfect way to realize that you need to engage someone on an individual journey so that they feel that they can have power over that very uncertain feeling that comes along with change. And change is hard. I think one of the spirit things we're going to talk about motivational interviewing, trying to change something, especially if there's a part of it you like, is an incredibly difficult task. So this is not about motivational interviewing, but it sometimes is a helpful construct to understand where someone enters treatment. Certainly in an action phase, when someone shows up saying, I want to change, I'm ready to do this, we all look like rocket scientists when we meet them and they change. But that's because they're at a much further stage of change than a lot of people. A lot of people, when they enter care, maybe in the pre-contemplation or contemplation stage. And this was really about understanding where someone is at the moment in time that you're meeting them. So pre-contemplation is this person hasn't even considered that this behavior is unhealthy or is causing them a problem. So maybe Lauren Swagger doesn't know that her chocolate even causes problems with her blood sugar. She just never thought about it before. That would be pre-contemplation. Contemplation means, yeah, I've heard of it, but I'm not really doing a whole lot or know what to do with it. It's might just stayed as an idea in my brain, but I haven't really gotten anywhere with it. Preparation is somebody that's maybe starting to acknowledge that they want to take some steps to do something different. Maybe they haven't implemented a plan. Maybe they're starting to think about not picking up the chocolate at the store the next time they go, or they're thinking about starting a diet or making an appointment. And then the action phase is really where it is easy to kind of motivate people. People are at a point of willingness to change. And then maintenance is something that occurs after the fact. And then another concept in this is relapse, that because we're talking about behaviors, there's always a risk of needing to maintain the health behavior and relapse. And a lot of these behavioral changes can easily slide backwards, especially with stress and triggers. And so we always have to be mindful of where someone might be in that cycle. Here are just some examples. These are related to smoking. Y'all can kind of take a look at this, but this may be things that people say to you that might suggest of where they are. And the goal of motivational interviewing, when we think about this, is, we're not going to take someone from pre-contemplation directly to maintenance or directly to action. That's an unrealistic goal. Yes, there are always great examples of people with one little nugget of knowledge might be able to change everything. But most of the time, it's a slow process of moving someone from pre-contemplation into contemplation, working with them again, getting them to preparation, and being there at each stage of those slow changes and recognizing that those slow changes are part of the pathway. I think sometimes in healthcare, at least I know I'm guilty of it, I want to go faster and I want to get to that end result before my patient's ready to do that. And so for a lot of providers, this is a process that can feel slow, but is a really critical part of the journey. So motivational interviewing is actually an interviewing technique. It's not a therapy per se, but it's a technique that was developed by Miller and Rolnick in the 1980s that was a tool to help people prepare and be ready for change. And this is where you'll hear a lot about the spirit of motivational interviewing, the idea that this isn't me being someone's boss or me telling someone what to do. This is me collaborating with them, being there to support them, to guide them. It is incredibly person-centered. It doesn't matter what I want. I have to facilitate what matters to that person. And I'll use smoking as an example. I may want someone to stop smoking so that their lung health improves or they have a longer life. This person might just want to stop smoking so they can see their grandkids because they're not allowed to. It's not, they don't want it. Their loved one doesn't want them around their grandkids if they're actively smoking. And their reason for change is far more important than my reason for change. And it's important that we know someone's reasons. And that's a real frame shift in a lot of healthcare workers. I know that's something a lot of professions teach, but medicine has not always been very good about understanding a person's reasons for quitting. And it's really a key concept. And so some of these principles, again, are how important things are of listening, being empathetic, helping them hear what they say. A lot of times the expressive things that people say, they may not be aware that they thought it or thought about it. And so sometimes as they say it, you put it in the room to kind of discuss it and work with it. This is completely non-judgmental, and you can't own someone not getting better as a failure for them or for you. It's part of the process. We talk about resistance and the idea that change always comes with resistance. And we don't get upset by that. We just roll with it. We go around it. And we always offer support and self-efficacy, that there's always a time that you can make a different choice or go a different direction. And so that are really key sort of philosophical principles that go with this. So I tell people, if you're in the process of doing motivation interviewing, probably at the beginning, the person should talk at least double amount of you, or at least 3 times more than you're speaking. You should be doing a whole lot more listening than talking. And that idea of giving advice comes way later. You have to ask permission to give advice, and we'll give some examples of that. You should be curious. You should be asking questions instead of delivering statements. We're going to talk about the skill of open-ended questions, using very concise, non-wordy, non-medicalized terminology. We let people talk. We don't interrupt. We're sitting alongside their journey and cooperating with them, listening for change language or that idea of discrepancy. We're listening for those things so we can reflect on it. The patient is the expert. And this is a really important concept if you haven't worked in this field before, is they are the expert at their reasons and behaviors. We are there to help them uncover an understanding of themselves and not be an expert on themselves. And that's really important. We're going to be curious about the pros and cons of the behavior. Again, what do they like about the behavior? What do they not like about the behavior? Even with behaviors that seem incredibly risky or dangerous, we have to acknowledge that there may be something positive about that and ask them what they like about it. We have to look and listen for that discrepancy between what they want and where they are. It is not, however, just being nice to people. It actually feels really nice to be listened to, but it is a substantial amount of effort. And I tell people, in motivational interviewing mode, my brain is working 1,000,000 miles an hour, listening, thinking, crafting how I want to phrase something. It really requires you to be in a good place to focus on it. It is not a solution to all problems, and there's sometimes when motivational interviewing is not the right solution. When people are actively psychotic from their substance use, or they're in a highly risky, life-threatening situation, that is not the time to do motivational interviewing. It's not the same as stages of change, but it can help you understand where someone is. And it's not just giving advice to people. So again, these are sort of the 4 pillars of what guides MI. It's a partnership. I'm not the boss. We're in this together. I'm going to accept you right where you are with everything that's going on. You have compassion, you have acceptance, and this idea of evoking from within them skills and powers they don't have to change. And so a lot of times we'll talk about the stages of MI. So you have to start with some degree of engagement, rapport building, to really understand what the goals are and an understanding of this behavior. The next phase is really focusing on that person's agenda and the goals that they may have, and then really spending time evoking some reasons for change or some skill development, and then setting up some long-term planning. And this can occur, the speed at which this can occur can be very, very different. Some people may stay in pre-contemplation for a very long time, and you can still use MI, meeting them every time they come to your office just to check on them. And eventually one day you might be able to move forward. Some people, again, at a different stage, could go very quickly with these changes. So, as you build rapport, you want to make sure you're comfortable, they're comfortable. Am I being supportive? Am I really listening to understand? And this is a really important concept. Am I listening to understand as opposed to listening to respond? You want to listen to truly understand. And your questions should be in the spirit of understanding what is going on. And does this feel like a partnership? If you don't feel any of these things in where you are with someone, advancing to the next stage is probably not going to be helpful. Focusing is really sort of once you sort of get a sense of some pre-contemplation or understanding of behavior, you can really start helping them focus on common purposes, common goals, things that you can move in the same direction together. I like this term, are we dancing together in our goal versus are we feel like we're fighting or wrestling, is a very important stage. Evoking is later in the process where you're really trying to build up someone's confidence and skills. And you want to make sure you're not moving too fast. But that again, you're sort of listening, and I'm gonna give you some terms here in a minute called sustained talk and change talk, and what someone is saying to you about where they are, and using that to kind of move it forward. And then planning. What people are able to accomplish between goals needs to be realistic. What sometimes prioritizing what the most important next step for someone is more important than giving them 10 steps. You want to really be offering information instead of giving advice, and we'll talk about some skills to do that. And then you want to make sure that you're continuing throughout this whole process to continue to be curious and help them own their success. And at the end of the day, the outcome in MI is that they own their success, that they feel that they've acquired skills and developed self-confidence in their skills, and not that you did it for them. So we sort of talk about what is an MI consistent behavior and MI inconsistent behavior and how we behave as clinicians. MI consistent behavior is always asking permission. And then we're going to talk about this concept of affirming, but affirming means that you are highlighting pro-health behaviors and making an effort to point out positives. People often discount positives, and you are making an effort at affirming the things that they are doing well and really emphasizing their freedom of choice, control, and autonomy. And so an MI consistent behavior is if someone doesn't want to be there, they are always free to leave. That is consistent with MI. Inconsistent with MI is I'm just going to give you advice. I'm not going to ask permission. I'm going to tell you what to do. I'm going to argue with you. I'm going to confront you. I'm going to blame you. I'm going to give you orders. I'm not going to really care about your own autonomy or where you stand. This is something that I didn't do for a long time, that I really learned to do as part of learning MI. And the great thing about asking for permission is that it gives people a sense of control. And if they want to say no, then you can be respectful of that. And so you have all this knowledge about something. Maybe it's positive behavior support. Maybe you're an expert at mountain climbing. You have an expertise in many things, but people might not welcome that. So how do I get my knowledge to someone else? Well, I should ask permission. So perhaps I know something really important about medications to help you quit smoking. I'm going to ask, I have some information about those medicines. Would you be interested in hearing about it? If they say no, I'm like, okay. But asking permission is really important. And sometimes clinicians, especially about sensitive subjects, and I always put those in sex, drugs, and rock and roll, that might be really important things to talk about. It's always a great way to start. Can I ask you some questions about your sexual health? Can I ask you some questions about your eating habits? This is a great way to approach sensitive topics with patients in a way that's empathetic, but sort of gets them a chance to say no. Most of the time people say yes, actually, but this is a really good way to be sensitive about that. So these are truly the really big skills of MI. This is how we evoke change. This is how we get people and how we elicit information about sometimes discrepancy, ambivalence. And it's called the Oars Technique. And it starts with open-ended questions. So what's the definition of an open-ended question? It's one you can't give a yes or no answer to. It requires people to talk. So it's really learning to ask questions in a way that encourages them to talk more than you. We're going to talk about affirmations. Affirmations are a little bit like cheerleading and pointing out those positives, but it's really important that we are only highlighting pro-health behaviors. If we affirm an unhealthy behavior, we will really do someone a great disservice. So affirmations are really, in the kid world, I call that we catch them being good. We look for those goods and we really try to affirm for them that we saw that and that they see those positives. And that can be a desire, that could be a behavior. We're really looking for those positives. Reflections are the thing that you do. It's a way of validating that someone's being heard. It's almost saying back to somebody what they just said to you, either a simple or complex way to let them know that you heard them, give a chance to correct it. And this is also something I think can feel really odd to people that don't practice reflection. And we'll talk about that more in a minute. And then summarizing statements are after you've talked for a while, you put it all together and help say it back to someone so that you really make sure you understood. I think the most important thing in this process is to make sure you're saving your summarizing statements for the end. If you summarize too soon, you might be making assumptions. So we'll talk about this dance a little bit more, but the summarizing part really comes once you really have gotten all your information. So just some examples of an open-ended question. And a lot of times this is a way we should probably start all encounters, is to just, again, you're looking for that elaboration. So how important is smoking to your daily routine? It's kind of a yes or no question, but then you can say, well, tell me more about your daily routine. What's that look like? When you get up, how does the day go? You're getting them talking. You know, if you couldn't have a cigarette today, how would you feel? You're kind of eliciting, you know, emotional expressive words and feeling words. What are your concerns about being here? Tell me what you like about your smoking. Tell me what you don't like about your smoking. What are some of the barriers that you've encountered to quitting? Again, all of these pull for more information to get the person talking to really understand their aversion. I might add, I would add to this. I think one of the challenges with open-ended questions in our current world of healthcare is we all have forms we have to complete in the electronic medical record, or questions and check marks, and it can, and people do not want to feel like you're being asked a questionnaire. So if you do need to gather information in a database, you can change all of those questions in a more open-ended way sometimes to still do this while getting the information you have. And I've had people say, well, it's faster to just ask all the close-ended questions. It's actually not. I actually made our trainees at one point time themselves taking histories if they just let the person talk about the problem versus if they screened in all the categories. It is substantially faster. And sometimes people tell you within a few seconds, or I'm sorry, a few sentences and a few minutes, everything you truly need to know that you would have lost if you just did closed-ended questions. So this is a really important skill that I think is eroding a little bit with all our electronicness that I'd like to come back to. Affirmations are really important. As people talk, you're going to hear them say a lot of negative things or concerns sometimes, but you're going to hear some amazing behaviors. And sometimes you really have to pull out the positives. So I give a couple examples about this. You know, you could have someone really frustrated. I'm using smoking as a lot of examples because that's what I'm going to talk about, smoking medications next. But you know, what if someone comes in, I'm so frustrated. I know you want me to quit. Everybody wants me to quit. I've tried 3,000 times to quit. This will never work. It's all going to think there was one little positive in there. Wow, you've tried 3,000 times to quit and you're still trying. That's amazing, right? You have to pull out the pro-health positive behavior that you hear sometimes in a lot of negative. This is that catch them being good part. And it usually comes with lots of things thrown in. It is also really important that you don't affirm the wrong behavior. Sometimes I call this not just being a cheerleader. You cannot, if you affirm a not healthy behavior, I'll give you an example. I had a kid who had cystic fibrosis, um, and he was worried about his lungs appropriately, so he stopped smoking and switched to chewing tobacco. Um, and he actually got an affirmation from a healthcare provider that that was a healthy behavior. Wow, I'm so proud of you for switching and using smokeless tobacco. And so that child took that using smokeless tobacco was healthy because that was not what we should have affirmed. What we should have affirmed is, wow, I'm really glad you're worried about your lung health. Quitting smoking was a really good choice to make. But I might still have some concerns about, let's talk more about the smokeless and see where that is. And so it's really important that we don't inadvertently affirm the wrong behavior. Reflective listening is really a very brain intensive activity. Even though you're not saying a lot, you really are, your brain is very active when you're reflective listening. And I found this one of the hardest things to do because it kind of felt like I was listening, I know what they're saying, but I didn't really appreciate it that they didn't know that I was paying attention or that I was hearing them. And so reflective listening as a clinician can feel strange because sometimes you literally say back to someone what they just told you. And that may not be, that may sound strange. So if someone says, wow, I'm so stressed out of the time smoking just really helps me relax. And you say, yeah, smoking really helps you relax. They really feel heard, but it also gives your client a chance. If you got that wrong, no, that's not what I meant. They have a chance to hear it too. Sometimes people say things and they're not aware of what they say. So it can be very, very important. I think it is really hard sometimes to get healthcare providers to say it back. I think it feels like too simple of a skill, but is incredibly important to people to feel heard. And a lot of people that do MI just, wow, that person really heard me. They really understood me. That is where it's really helpful. And this is the stage of this endeavor where you're really that reflective listening. You're listening for these concepts of change talk and sustained talk that we're going to talk about more. So, and again, of course, people don't label this for you, so you have to be actively listening for it. Change talk is all the reasons I might consider changing or all the benefits I may have from change. So if you talk about, someone struggling with their weight, you might hear, wow, if I lost weight, I'd be able to breathe better. I wouldn't get as exhausted by my kids. I just would feel so much better. Those are all the reasons they might want to change. Sustained talk are kind of like the barriers. But to lose weight, I would have to exercise. Where am I going to find time for that? I get sick every time I exercise. And you're going to hear someone, and this, when you hear the change talk and you hear the sustained talk, that's the ambivalence that you're pulling out regarding this behavior. That's really a positive thing. And of course, we all tend to sometimes emotionally charge the negative. And so listening for the change talk may be something that they're not recognizing as much as the sustained talk. So you are really actively trying to pull those things out. And the change talk can often be across some of these categories. And there's an acronym called DARN CAT that might help sort of elicit it. And you can also ask open-ended questions using this acronym sometimes to sort of gauge positive talk. So, why might you desire to stop smoking? What would be your reasons for stop smoking? And so you could also listen, but also elicit some of this in your question. So D is what are the desires I have for change? A is ability. Do I feel able to change, or do I not feel like I have a skill that I can't change? Reasons, what matters to me about changing? What do I need to change? Is my health jeopardized? Do I have to do this? Commitment is, whether or not someone feels like they're owning the process or it's being done to them. Are they talking about some of those active steps that they're taking toward change and getting excited, or are they actually taking steps to change? And anytime you hear change talk, that is a movement to affirm and say back to them that they are exhibiting a pro-health behavior. Sustained talk is the failures, the negative part, the hopelessness that goes with inability to change. And so you're going to hear this as people are talking. And again, here are just some examples that might come out. And as I said, they often come out all together. One sentence might be changed, one may be sustained. And so you can see some differences here. And again, as you're listening to this, you can reflect back to make sure you understand. But if you hear if you hear sustained talk, you can often reflect. When you hear change talk, you can both reflect it and affirm it as a pro-health behavior. And so if you look at that second one, I'm sick of going to the dentist and hearing about all my dental problems. That's actually change talk, but worded in you can word that back in a positive way. I hear that you're struggling with all your dental problems, but that's amazing that you are still going to the dentist and making efforts to work on them. So you can reframe that. And again, as you hear this and it's coming at you with the sustained change talk, you can help shape the conversation. And over time, you will see sessions progress as you're having them get more comfortable with recognizing the change talk and the positive talk. And so some of the mobilizing language comes a little bit later. You've told me all these things. What would you like to do? What would you be willing to do? What steps have you already taken versus just that information gathering sort of stage? Summarizing is really something, again, you do toward the end. When you really have an understanding of all the factors that played into those antecedents and the consequences of a behavior, you might summarize it in a few sentences and say it back to someone to make sure you truly understand it and that they can hear it and that you can make sure it's right and you can correct it if it's not, so that they really feel understood and you really understood where they are. Another technique within motivational interviewing is something called scaling, and recognizing that how important something is and how someone is confident about their ability to change can play a real role in that. And so we talk about a health behavior being important to someone or how confident they can be in terms of changing. And so understanding where someone is with this can also be really helpful. Sometimes you have people that have high confidence in themselves, but they don't see why change is important. Sometimes it's the reverse. They feel it's really important, but they don't have any confidence in their own skills to change it. Sometimes they're just stuck in the middle with both, but they can be very different. Sometimes you want to ask directly how people are doing. And so we often, during the course of questioning, can do something called a scaling technique. You want to know how important it is to someone. So how important is it that you give up chocolate in your diet? It's a 2. That is not very important. And then this is the trick. After they tell you the number, you always want to ask why it's not lower. Does anybody know why you ask lower instead of higher?
I'll help monitor the chat for you, Dr. Sliker.
Okay, thank you. Well, so part of that is psychologically asking for the lower answer makes people give you a positive answer to explain why it's higher, right? So you're eliciting more sort of positive pro-directional advice, but it also, a lot of times I think people will want you to ask the opposite, and that can get worded negatively. So asking about the lower number helps them verbalize reasons that are often more positive or change talk, and is a much more non-judgmental way of asking. So you always want to figure out how important it is. The next question is, how confident are you that you can do this? Also gives you information, but also even if they give you a high number, like, oh, I'm a 10. Okay, why aren't you an 8? They still have to then give you some reasons about why they feel confident. And then that can also help with some affirmations of pro behaviors. But this can be a skill that you can use to kind of elicit, again, where someone is and also some of the barriers. So over the course of time, and we spent a lot of time talking about this, But I tell people in motivational interviewing, you can spend 5 minutes with someone doing some MI, you can spend 20 minutes doing with someone. Sometimes you deliver MI 5 minutes here, 10 minutes here, 10 minutes here. This is really a process. And so I like to think of it as a dance. So over the course of you talking to someone about a behavior, you're going to go back and forth. And so these are skills that you might do when talking to someone. So what I might do is ask you an open-ended question. Tell me about your smoking. If I get some answers, I might reflect. I might keep saying back to them what I hear, make sure I clarify it. When I hear something like a good aspect of change talk, or I hear a pro-health behavior, I might affirm it. And so I'm going to go back and forth, open-ended question, reflect, open-ended question, reflect, open-ended question, affirm, open-ended question, reflect, open-ended question, reflect. I'm collecting all my information, affirming when I can, reflecting, making sure I understand it. And as I get more information, then I might throw in some scaling questions to, again, see where they are. And then as I learn more and more, I'm moving into more summarizing sort of mode. And that is how it may progress a little bit over time. Now, what I will say is this is the engagement strategy. So once you have really engaged people and you start seeing motion toward change, this is where you, in the process of helping someone, can start using other skills. And this is where we would go into sort of the next phase of treatment. When someone's really ready to make a change, that's when you can ask permission to share things that might be helpful to them, or help them in some goal setting, or move into cognitive behavioral work or other types of work that you might think benefit them. But if you don't engage them and you don't get to this process of understanding, it makes those other things more challenging. So for me, MI is always sort of the first strategy before I sort of decide the longer term plan, or even knowing what maybe the best intervention is. And for me, it's always a process of slowing down my brain and not jumping to the solution, but realizing that whole process is really important. So just in summary, again, this was the very didactical part of the foundation of MI. As I said, I would be more than happy to do some more live action work and videos if people are interested. But the understanding, again, that you have to understand all parts of a behavior, sort of that you need to know where someone is, and then use MI to sort of see about their willingness to change. But the spirit of MI of really being non-threatening, engaging, is so important as just a frame shift to really help people embrace success. And then those tools, those things that you as the clinician can do to really help listen and ask the right types of questions to display that curiousness, and really listen for that idea of change talk and sustained talk to help people engage them on their journey, are really at the foundation of understanding this. So I will pause and see what other people's thoughts are. I also, as I said, to me, motivational interviewing was a very life-changing clinical experience. I'm really curious if anyone else is using this or what benefits they've had, but I have had far more success at getting people better since I started doing this. And then, as I said, they really own their success. That I think sometimes it feels like magic, even though it's really not, but it really has been that powerful. So I'm really curious if anyone has any experience or thoughts about this, because I'm gonna look like I'm on cloud 9 about it, because I am, but I'm really curious to see what you all know about this.
Thank you so much, Dr. Swagger, as always. And what an important topic you presented today. We really appreciate it. But yeah, open up for questions. Jerry, I saw you had your video on. Did you have a question or comment?
No question. And boy, you're quick on watching people flip their buttons, aren't you? So thank you for that. I just wanted to just echo what Dr. Swagger said. I've been doing, probably obvious by my gray hair, I've been in medicine a long time, but probably been doing motivational interviewing for over half of that career. And as you mentioned, it's been a game changer. It's the conventional way of medicine is to tell patients what they should do. And we're slow learners, but that just doesn't work. This is, again, I'll just stop there, but yeah, thanks for the presentation. And I agree with everything you said about being a game changer.
Thank you so much, Jerry. And Cheryl chatted in. She goes, I felt really called out today, Dr. Swagger, as someone trying to quit smoking and with the holiday Reese's problem, LOL. But she said she really does appreciate the things you've given her to think about personally and professionally today. Thank you, Cheryl. And Teresa, I see you chatted in as well. Teresa said, I've worked with children in behavioral change for many years. When the kids are old enough to think about their behavior, it is much easier to help them affect change when they are a part of it. Thank you so much for that, Teresa. Alicia, I see you unmuted. Did you have a comment as well?
I just wanted to say we do use this sometimes in the SEMP program, motivational interviewing, kind of to initiate prescriber changes, not necessarily patient-based. But one thing in going through some motivational interviewing training that I've used in the past that I found to be interesting and really kind of a check is in expressing empathy and using the phrase, I understand, and how it can really kind of be patronizing to the patient and viewed negatively. So trying to avoid that sometimes is very hard, but just a food for thought for everyone and tip for everyone.
That's a really great point. And sort of going off of that, Danielle chatted in saying that is a great skill to develop for personal relationships as well in our lives. Being heard and understood is everything. Absolutely. Heather, I see you unmuted.
Yeah, I've used motivational interviewing when working with parent support groups and parent education groups, and even just one-on-one with parents. I have found they find out more about themselves and what they're doing with their child when you use these types of questions, when sitting down to try to, problem solve with them or come up with ways to support them with whatever the issue they're having with their child's behavior. And so I have found it to be very useful, I guess it's a psychological way. The parents don't realize I'm really interviewing them, but it pulls out more information, and then they have an aha moment about themselves, knowing, oh, I actually am doing this, or this is achievable and I can work towards that. So I love using this. I think it's such a great tool to have. Thank you. Excellent presentation.
Thank you for that comment, Heather. And we're getting a lot of great things in the chat over here. I'll read some of them out loud. And at any point, if any of you wanted to kind of expand on your comments, please do interrupt me. So Terry said, I think this will really help my patients open up in the ED when they come in for an acute change in their mental status or situation. This will hopefully allow me to really get to the root of their problem. Thank you. And Sherelle also thanking you, Dr. Swagger, for a great presentation. Always wonderful to hear your voice and listen to your perspective, to be in your presence. That's so sweet of you, Sherelle. Thank you. And Rob commented as well, I have experienced that the system sometimes has a different time schedule than MI does. I find MI may take a little more time, but have more lasting, impactful outcomes. And Teresa was agreeing, Colleen as well agreeing. So if anyone, please cut me off, would like to expand on that, Dr. Swagger.
Well, I did want to say about the time, because I think you're exactly right. It does take a little bit more time at the front end, but really does affect change. And for those of you that might be billing, especially E&M codes or therapeutic codes, or have the ability to do that, this is really where you can sort of revert to using time-specific billing as still a problem-specific billing, and still sort of justify your time and sort of get paid for the time. And so if you have the ability to do that, I could give you a whole separate lecture on that, but I have certainly billed time to just do motivational interviewing, and not feel constrained as much by the system, and had more meaningful outcomes. So the other area where, as I said, I have really found that personally it does save me time is to really get out of the mindset of those checkbox answers I'm always supposed to do, because oftentimes I will change that to an MI approach and get all the information I need, but faster, even though it may not seem like that. And so And I actually timed myself too, as well as trainees doing it. It really is faster. If people feel like they can just talk, they'll often tell you the answers to all those things much quicker than if you're just going down the list. So the time is really a perception that is, I think, is something we need to always keep working on. So I'm really glad someone said that.
Thank you so much, Dr. Swagger. Any other comments, questions from the group, or anyone who wanted to expand on their chat comments? And anything else, Dr. Swagger? I know you just did the whole presentation, but anything else before I go into announcements that you maybe wanted to say or anything?
Well, I would comment, people talk about it like working in all relationships. It sure does. Like, go home and practice motivational interviewing on your significant other. It works everywhere. It is like little magic pixie dust.
I love that. And I'm going to do the same thing in my household. Alrighty, and as always, if anyone has questions after the session ends, you can always shoot us an email and we'll make sure to have it addressed. As far as cases go, if anyone has cases of patient situations, scenarios, policy type of things, anything, it can even just be a simple question. It doesn't have to be a full-on case presentation. We always encourage you all to submit that. I'll have it in the recap email to go to the direct link if that's something you're interested in. In the past, we've had great discussion. It's a great learning experience that goes hand in hand for the session in general, but it doesn't have to be related to the didactic topic. So that's something we always like to highlight as well. But I know some of you are sort of new to ECHO, so I just wanted to put that little plug in there. If the case presentation sounds daunting, you can always reach out to us as well about that. We'll help you submit one, and we're always there along the way. So you're never alone with that if you have any questions. But the only announcement that I have is that the next session will be on October 19th, and Jennifer Ludrowski will be presenting on pediatric GI psychology. So keep an eye out for that reminder. Have a wonderful rest of your day and week, and we look forward to seeing you all next time. Thanks, everyone.
Bye.